Good day. Today I will discuss diabetic ketoacidosis. My reference, as always, is Tintinelli's Emergency Medicine. Diabetic ketoacidosis is an acute life-threatening complication of diabetes mellitus. DKA occurs predominantly in patients with type 1 or insulin-dependent diabetes mellitus, but 10 to 30% of cases occur in newly diagnosed type 2 or non-insulin dependent diabetes mellitus. There are complex relationships between insulin and counter-regulatory hormones. DKA is a response to cellular starvation brought on by relative insulin deficiency and counter-regulatory or catabolic hormone excess. Insulin is the only anabolic hormone produced by the endocrine pancreas and is responsible for the metabolism and storage of carbohydrates, fat, and protein. Counter-regulatory hormones include glucagon, catecholamines, cortisol, and growth hormone. Complete or relative absence of insulin and the excess counter-regulatory hormones result in hyperglycemia due to excess production or underutilization of glucose, or both, osmotic diuresis, pre-renal azotemia, worsening hyperglycemia, ketone formation, and a wide anion gap metabolic acidosis. Ingested glucose is the primary stimulant of insulin release from the beta cells of the pancreas. Insulin's main action occurs at the three principal tissues of energy storage and metabolism: the liver, adipose tissue, and skeletal muscle. Insulin acts on the liver to facilitate the uptake of glucose and its conversion to glycogen, while inhibiting glycogen breakdown or glycogenolysis and suppressing gluconeogenesis. So again, insulin is an anabolic hormone. In fact, it is the only anabolic hormone produced by the pancreas, and it acts on the liver, facilitating the uptake of glucose and its conversion to glycogen, which is called glycogenesis, and it inhibits glycogen breakdown, also known as glycogenolysis, suppressing gluconeogenesis. The net effect of these actions is to promote the storage of glucose in the form of glycogen. Insulin increases lipogenesis, or the creation of fat in the liver and adipose cells, by producing triglycerides from free fatty acids and glycerol, while inhibiting the breakdown of triglycerides. Insulin stimulates the uptake of amino acids into muscle cells with subsequent incorporation into muscle protein, while preventing the release of amino acids from muscle and hepatic protein sources. So, when a person has insulin deficiency and an excess of counter-regulatory hormones, primarily glucagon, you will notice cellular underutilization of glucose and an increase in hepatic gluconeogenesis, which leads to hyperglycemia. And when there's an excess of glomerular Tmax for glucose, glycosuria would occur. And glycosuria causes osmotic diuresis with a loss of sodium, chloride, phosphate, potassium, calcium, magnesium, and nitrogen. This also leads to a decrease in GFR and severe hyperglycemia. Basically, it's a cycle. And severe hyperglycemia can cause intracellular dehydration and hemoconcentration. And intracellular dehydration leads to an impairment in consciousness, whereas dehydration and hemoconcentration leads to shock. Other effects of insulin deficiency include lipolysis, which causes fatty acid transport to the hepatocytes, and via carnitine transferase 1, this is brought to the hepatic mitochondria. Beta oxidation occurs, and keto acids are produced. An excess of keto acids, which is the ketoacidosis part of DKA, can lead to vomiting, anion gap, metabolic acidosis, ketonuria, and compensatory tachypnea. So the compensatory tachypnea is another mechanism, along with vomiting, that leads to dehydration and hemoconcentration that can contribute to shock. And with insulin deficiency, there's also a breakdown of proteins, and as a result, there's a loss of nitrogen and muscle wasting. So that is the full pathogenesis of diabetic ketoacidosis, secondary to relative insulin deficiency and counterregulatory hormone excess. Deficiency in insulin secretion due to loss of islet cell mass is the predominant defect in type 1 diabetes mellitus. In the initial stages of diabetes mellitus, the secretory failure of B cells impairs the fuel storage and may be evident only during a glucose tolerance test. As levels of insulin decrease, fuel stores are mobilized during fasting, resulting in hyperglycemia. When pancreatic B cell reserves are present, hyperglycemia may trigger an increase in insulin and a return to normal glucose concentration. With further degrees progression, hyperglycemia can no longer trigger an increase in insulin activity. Despite the presence of elevated intravascular glucose, in the absence of insulin, cells are unable to use glucose as a fuel source. The body responds by breaking down protein and adipose stores to try to produce a usable intracellular fuel. Loss of the normal physiologic effects of insulin leads to secretion of catabolic or counterregulatory hormones and resulting hyperglycemia and ketonemia. The responses to cellular starvation seen with insulin insufficiency is increased levels of glucagon, catecholamines, cortisone, and growth hormone. Glucagon is the primary counterregulatory hormone of insulin. The catabolic effects of these hormones include increased gluconeogenesis and glycogenolysis, which insulin is supposed to prevent, breakdown of fats into free fatty acids and glycerol, and proteolysis with increased levels of amino acids. Increased levels of glucogenic precursors such as glycerol and amino acids facilitate gluconeogenesis, worsening hyperglycemia. Free fatty acids released in the periphery are bound to albumin and transported to the liver, where they undergo conversion to ketone bodies. The primary ketone bodies, beta hydroxybutyrate and acetoacetic acid, account for the metabolic acidosis seen in DKA. The two are in equilibrium, in which acetoacetic acid plus NADH has an equilibrium with beta hydroxybutyrate and NAD. Acetoacetic acid is metabolized to acetone, which is another major ketone body. Depletion of hepatic glycogen stores favors ketogenesis. Lower absent insulin levels decrease the ability of the brain and cardiac and skeletal muscle to use ketones as an energy source, increasing ketonemia. The persistently elevated serum glucose level eventually causes an osmotic diuresis. The resulting volume depletion worsens hyperglycemia and ketonemia. The renin-angiotensin-aldosterone system, activated by volume depletion, exacerbates renal potassium losses already occurring from osmotic diuresis. In the kidney, chloride is retained in exchange for the ketoanions being excreted. The loss of ketoanions represents a potential loss of bicarbonate. In the face of marked ketonuria, a superimposed hyperchloremic acidosis is also present, which leads to an anion gap metabolic acidosis. As adipose tissue is broken down, prostaglandins I2 and E2 are produced. Both account for paradoxical vasodilation that occurs despite profound levels of volume depletion. Factors that are known to precipitate DKA include omission or reduced daily insulin injections, dislodgement or occlusion of insulin pump catheter, infections, pregnancy, hyperthyroidism, pheochromocytoma, Cushing syndrome, substance abuse, especially cocaine, steroids, thiazides, antipsychotics, and sympathomimetics, heat-related illness, cerebrovascular accidents, gastrointestinal hemorrhage, myocardial infarction, pulmonary embolism, pancreatitis, major trauma, and surgery. Additional risk factors include poor economic background, lack of insurance or minority status, drug abuse, depression, and the presence of an eating disorder. Many patients have no clear precipitating cause for DKA. The clinical manifestations of DKA are related directly to hyperglycemia, volume depletion, and acidosis. The metabolic alterations that occur tend to evolve within 24 hours. Osmotic diuresis gradually leads to volume loss in addition to renal losses of sodium, chloride, potassium, phosphorus, calcium, and magnesium. Initially, patients may compensate by increasing fluid intake, and polyuria and polydipsia are usually the only symptoms until ketonemia and acidosis develop. As acidosis progresses, ventilation is stimulated physiologically by acidemia to diminish the PCO2 and to counter metabolic acidosis. Acidosis combined with the effects of prostaglandins I2 and E2 leads to peripheral vasodilation despite profound levels of volume depletion. Prostaglandin release is also felt to play a role in unexplained nausea, vomiting, and abdominal pain seen frequently at presentation, especially in children. Vomiting, which may be a maladaptive physiologic response to diminish the acid load, unfortunately exacerbates potassium losses. As volume depletion progresses, poor absorption of subcutaneous insulin renders its administration ineffective. Impaired mental status may develop and is most likely multifactorial, related to metabolic acidosis, hyperosmolarity, low extracellular fluid volume, and poor hemodynamics. Alteration of consciousness has been reported to correlate better with elevated serum osmolality greater than 320 milliosmoles per liter or greater than 320 millimoles per kilogram than with severity of metabolic acidosis. Tachycardia, orthostasis, or hypotension, poor skin turgor, and dry mucous membranes result from volume depletion. Cosmal respirations, increased rate and depth of breathing may be observed. Acetone produces the characteristic fruity odor on the breath found in some patients. The absence of fever does not exclude infection. Hypothermia is present occasionally because of peripheral vasodilation. Abdominal pain and tenderness associated with DKA generally correlate with the level of acidosis. Pain can be due to gastric dilatation, ileus, or pancreatitis, but any other acute abdominal disorder can also develop. Due to the frequency of abdominal pain and the presence of an elevated serum amylase or lipase level in both DKA and pancreatitis, distinguishing these two conditions may be difficult. An elevated serum lipase level is more specific to pancreatitis, but may also be elevated in DKA. So for diagnosis, a blood glucose level of more than 250 milligrams per deciliter or 13.8 millimoles per liter, and an ion gap of more than 10 mEq per liter, which is equal to more than 10 millimoles per liter, a bicarbonate level of less than 15 mEq per liter or also less than 15 millimole per liter, and a pH of less than 7.3 with moderate ketonuria or ketonemia constitute the diagnosis of DKA. So to break that down again, you need to have a blood glucose level that's more than 250 milligrams per deciliter, an anion gap of greater than 10, a bicarbonate level of less than 15, and a pH of less than 7.3 with moderate ketonuria or ketonemia. Patients may sometimes present with euglycemic ketoacidosis, which is glucose less than 300 milligrams per deciliter, such as those who present just after receiving insulin, type 1 diabetics who are young and vomiting, patients with impaired gluconeogenesis through alcohol abuse or liver failure, patients with low caloric intake or starvation, patients with depression, or pregnant patients. Euglycemic DKA has recently been described as an adverse effect of sodium glucose cotransporter 2 inhibitors such as canagliflozin and others. We check blood ketones, venous pH, bicarbonate levels, and anion gap to avoid missing euglycemic DKA because the degree of hyperglycemia may not be significant. The differential diagnosis includes any cause of a high anion gap metabolic acidosis. Patients with hyperosmolar non-ketotic coma tend to be older, have a more prolonged course, and have prominent mental status changes. Serum glucose levels generally are much higher at greater than 600 milligrams per deciliter or more than 33.3 milliosmoles per liter, and there's little to no anion gap metabolic acidosis. The ketosis in alcoholic ketoacidosis and starvation ketosis tend to be milder, and the serum glucose level is usually low or normal. Beta hydroxybutyrone predominates in alcoholic ketoacidosis, so the urinary ketone test may be negative or trace positive. If an ingestion cannot be excluded, serum osmolarity or drug level testing is required. Renal failure, anion gap acidosis, and liver function abnormalities may be due to paracetamol toxicity. Depending on hemodynamic status, lactic acidosis through poor perfusion may occur simultaneously with DKA, and in these cases, determination of the serum lactate level is indicated. Patients on metformin with new onset renal insufficiency are at risk for developing type B or aerobic lactic acidosis. So, risk factors for diabetic ketoacidosis patients with initial glucose of less than 300 milligrams per deciliter or euglycemic ketoacidosis are patients who present shortly after receiving insulin, type 1 diabetics who are young and vomiting, patients with impaired gluconeogenesis through alcohol abuse or liver failure, low caloric intake or starvation, depression, and pregnancy. So, when it comes to laboratory testing, it's important, of course, to determine glucose levels, get a urine test strip for glycosuria, and an EKG to check for hyperkalemia, And we obtain CBC, serum electrolytes, BUN, creatinine, urinalysis, venous blood gas, and phosphate, magnesium, and calcium levels, mostly to evaluate renal function and sources of possible infection, inflammation, and the like. We calculate the anion gap because it's important for the diagnosis. It should be more than 10. It's bicarbonate that has to be less than 15. Blood cultures and other laboratory tests should be done as clinically indicated. Arterial blood gas determinations are optional but may be required for diagnosing and monitoring critically ill patients. So in DKA, there are elevated serum levels of ketones, which causes acidosis and ketonuria or ketonemia. The nitroprusside reagent normally used to detect urine and serum ketones only detects acetone, basically, well, not acetone itself, but the precursor to acetone. Acetone on its own is only weakly reactive, and beta hydroxybutyrate not at all. Gas chromatography can be used to detect serum acetone, but it is expensive and time consuming. NADH accumulation in the mitochondria, as may occur with lactic acidosis or alcohol metabolism, favors the beta hydroxybutyrate side of the equilibrium noted earlier. Paradoxically, as the patient is being treated and clinically improves, ketone levels will increase as the body converts the more acidic beta hydroxybutyrate to the precursor for acetone. So when we go back to that, that's acetoacetic acid. Therefore, the blood ketone test that uses the nitroprusside reaction is not a reliable measure for diagnosis or monitoring of DKA. Although not widely available, there's also a capillary blood ketone test for beta hydroxybutyrate levels, which may be more sensitive and specific than traditional testing for urine ketones. DKA leads to a wide anion gap of more than 10 metabolic acidosis. Hyperchloremic acidosis also occurs on the basis of keto anion exchange for chloride in the urine and is especially common in patients who maintain good hydration status and glomerular filtration rate despite ketoacidosis. Metabolic alkalosis may occur secondary to vomiting, osmotic diuresis, and concomitant diuretic use. Rarely, some patients with DKA may present with normal appearing bicarbonate or even an elevated bicarbonate if coexisting metabolic alkalosis is severe enough to mask the acidosis. In such situations, an elevated anion gap may be the only clue to the presence of an underlying metabolic acidosis, otherwise masked by the concomitant volume contraction related metabolic alkalosis. So, when it comes to differential diagnoses for that diabetic ketoacidosis, you can include the other types of ketoacidosis, which are alcoholic and starvation related, renal failure, lactic acidosis, and ingestion of salicylates, ethylene glycol, and methanol. Venous pH has essentially replaced arterial blood gas in the assessment of the acid base status of the DKA patient. A strong correlation exists between venous and arterial pH in patients with DKA, and the arterial blood gas value does not impact therapy. Venous pH is about 0.03 or rather just 0.03 lower than arterial pH. Venous pH obtained during routine phlebotomy should be used to avoid arterial puncture, or rather arterial puncture, which is painful and may cause arterial vascular complications. A low PCO2 determination usually reflects respiratory compensation for metabolic acidosis. If it is lower than explained by the degree of acidosis, a primary respiratory alkalosis exists, which may be an early indication of pulmonary disease such as pneumonia or pulmonary embolus, or sepsis as a possible trigger of DKA. Total body potassium is depleted by renal losses. However, the measured serum potassium level is normal or elevated in most patients because of two important factors: extracellular shift of potassium secondary to acidemia and increased intravascular osmolarity caused by hyperglycemia. Although the actual incidence of initial hypokalemia in DKA is not known, a few studies report an occurrence of 4 to 6%. The decrease in serum potassium during therapy is reported to be about 1.5 mg per liter and parallels the drop in glucose and the dose of insulin. EKG changes of hyperkalemia or hypokalemia may be seen. The EKG should also be evaluated for ischemia because myocardial infarction may precipitate DKA. When it comes to sodium and other electrolytes, osmotic diuresis leads to excessive renal losses of sodium chloride in the urine. However, the presence of hyperglycemia tends to artificially lower the serum sodium levels. Standard teaching is that 1.6 mg should be added to the reported sodium value for every 100 milligrams of glucose. However, the correction factor is probably 2.4, especially for blood glucose levels greater than 400 milligrams per deciliter. Osmotic diuresis also causes urinary losses and total body depletion of phosphorus, calcium, and magnesium. Hemoconcentration frequently leads to initially elevated levels of these electrolytes in serum. As therapy progresses, lower serum levels of each will be evident. Serum creatinine frequently may be elevated factitiously if the laboratory assay for creatinine is interfered with by the nitroprusside assay. Some elevation in creatinine is expected due to prerenal azotemia. Liver function studies may be elevated because of fatty infiltration of the liver, which gradually corrects as the acidosis is treated. Leukocytosis is often present because of hemoconcentration and stress. However, a WBC count of more than 25,000 millimeter cube and or an absolute bad count of 10,000 millimeter cube or more is suggestive of infection. Elevation of CRP may reflect pro-inflammatory state found in DKA, but again, it's nonspecific, and elevated levels of cytokines may also be present. The diagnosis of DKA should be suspected at triaging, and aggressive fluid therapy should be initiated before receiving laboratory results. We place patients on a cardiac monitor and begin at least one large bore, 16 to 18 gauge, IV infusion of normal saline. A second IV line with 0.45% normal saline at minimal rate to keep the IV line open can be considered. Goals of therapy include volume repletion, reversal of the metabolic consequences of insulin insufficiency, correction of electrolyte and acid base imbalances, recognition of treatment of precipitating causes, and avoidance of complications. The order of therapeutic priorities is volume first and foremost, correction of potassium deficits, and then insulin administration. Metabolic disturbances should be corrected at the approximate rate of occurrence or over 24 to 36 hours. Meeting the goals of safely replacing deficits and supplying missing insulin requires monitoring every 2 hours of electrolytes for glucose, potassium, and an ion gap, vital signs, level of consciousness, and volume input or output until recovery is well established. The goal of treatment is glucose of less than 200 milligrams per deciliter, bicarbonate of more than or equal to 18 mg per liter, and a venous pH of more than 7.3. So when it comes to treatment, on brief history and examination, we start monitoring the patient. We check for glucose, EKG, urine, serum ketones, and we insert two IV lines, one with normal saline, 15 to 20 milliliters per kilogram per hour for the first hour, and another one with zero point 0.5 normal saline just to keep the vein open. We send electrolyte CBC, phosphate, calcium, magnesium, venous blood gases, consider urine and blood culture. If glucose is greater than 250, urine plus ketones, assume DKA, and we search for precipitant and infection in this patient. We check the EKG for hyperkalemia, infarction, and give a Foley catheter as needed. So if the initial potassium value is greater than 5.2, we initiate an IV infusion of regular insulin at zero point 0.1 to 0.14 units per kilogram per hour. We repeat potassium stat in 2 hours. If the initial potassium is greater than 3.3 and less than 5.2 and urine output, we add 20 to 30 mg of potassium to each liter of fluid and insulin drip as above. If the initial potassium is less than 3.3, we hold insulin drip and give potassium at 20 to 30 mg per hour until potassium is greater than 3.3, then initiate insulin drip as earlier. So initial electrolytes are to check osmolarity and then corrected potassium and sodium. So, initial potassium determines further therapy, and adequate urine output is essential before initiating potassium therapy due to the effects on the urine and renal function in general. So, glucose electrolytes are repeated, and if glucose is more than 800 or there's a significant comorbidity, we consider ICU disposition. After giving a normal saline bolus, generally for eunatremia or hypernatremia, give 0.45 normal saline at 250 to 500 ml per hour with potassium supplement as above. For hyponatremia, continue normal saline at 250 to 500 milliliters per hour. And if pH is less than 6.9, you may give 100 millimoles of sodium bicarbonate in 400 ml of water with 20 equivalents of potassium chloride at 200 ml per hour. We repeat every 2 hours until pH is more than 7.0. Then we check potassium every 2 hours. So the rate of hydration is dependent on hemodynamics, hydration status, and urine output. Patients with a pH of greater than 6.9 do not require sodium bicarbonate. Active goals include adequate fluid infusion, insulin infusion, maintaining potassium between 3.3 to 5.2, lowering glucose by 15 or rather 75 milligrams per deciliter per hour, and maintaining adequate electrolytes. When glucose approaches 200, we change IV to D5.5 normal saline with 20 to 40 milliequivalents of potassium chloride per liter and or decrease insulin rate to 0.02 to 0.05 units per kilogram per hour. We check glucose and everything basically every 2 hours initially, but that's for electrolytes. We check glucose hourly. If blood glucose does not decrease by 10% or 3 millimole per liter per hour after 1 hour of insulin therapy, give 0.14 units per kilogram bolus, then resume previous rate. We also correct the estimated fluid deficits in the first 24 to 36 hours and maintain a serum glucose of 180 to 200. Continue insulin drip for at least 12 hours or until DKA resolves with a glucose of less than 200 and AG normal, pH of greater than 7.3, and bicarbonate of greater than 15. For patients who are able to eat, we give subcutaneous short and long acting insulin, feed the patient, discontinue IV insulin 1 to 2 hours after subcutaneous insulin. Late complications may include refractory acidosis and sepsis, cerebral edema, vascular thrombosis, which is rare, ARDS, and mucormycosis, which is also rare. When it comes to volume repletion, fluid helps restore intravascular volume and normal tonicity, perfuse vital organs, improve glomerular function rate, and lower serum glucose and ketone levels. Rehydration improves the response to low-dose insulin therapy. The average adult patient has a water deficit of 100 milliliters per kilogram, so that's around 5 to 10 liters, and a sodium deficit of 7 to 10 milliequivalents per kilogram. Normal saline is the most frequently recommended fluid for initial volume repletion, even though the extracellular fluid of the patient is initially hypertonic. Normal saline does not provide free water to correct intracellular fluid loss, but it does prevent an excessively rapid fall in extracellular osmolarity and the potential devastating transfer of excessive water into the CNS. After initial resuscitation with normal saline, change fluids to 0.45% normal saline once the corrected serum sodium is normal or elevated. Based on clinical suspicion alone and before initial electrolyte results, we administer the initial fluid bolus of isotonic saline at a rate of 15 to 20 milligram per kilogram per hour during the first hour, unless there are mitigating circumstances. The rate of hydration should depend on hemodynamic stability, hydration status, urine output, and serum electrolytes. After the initial bolus, administer normal saline at 250 to 500 cc per hour in hyponatremic patients or give 0.45% normal saline at 250 to 500 cc per hour for eunatremic and hypernatremic patients. In general, the first 2 liters are administered rapidly over 0 to 2 hours, the next 2 liters over 2 to 6 hours, and then an additional 2 liters over 6 to 12 hours. This replaces approximately 50% of the total water deficit over the first 12 hours, with the remaining 50 water deficit to be replaced over the subsequent 12 hours. When the blood glucose level is 250 milligrams per deciliter, change to 5% dextrose in 0.45 normal saline. Patients without extreme volume depletion can be managed safely with a more modest fluid replacement regimen, such as 250 to 500 ml per hour for 4 hours. Consider central venous pressure or pulmonary artery wedge pressure monitoring in the elderly or those with heart or renal disease. Excess fluid may contribute to the development of adult respiratory distress syndrome and cerebral edema. Patients in DKA usually present with profound total body potassium deficits in the range of 3 to 5 mg per kilogram. This deficit is created by insulin deficiency, metabolic acidosis, osmotic diuresis, and frequent vomiting. Only 2% of total body potassium is intravascular. The initial serum concentration is usually normal or high because of the intracellular exchange of potassium for hydrogen ions during acidosis, the total body fluid deficit, and diminished renal function. Initial hypokalemia indicates severe total body potassium deficits, and large amounts of replacement potassium are usually necessary in the first 24 to 36 hours. Correction of the acidosis predicts the change in serum potassium concentration. For each zero point 0.1 decrease in pH, serum potassium concentration rises approximately zero point 0.5 milliequivalents per liter, and the same relationship holds as the pH increases. This can be used as a guide for estimating the serum potassium concentration when pH balance is restored. During initial therapy for DKA, the serum potassium concentration may fall rapidly, largely due to the action of insulin promoting re-entry of potassium into cells and to a lesser degree the dilution of extracellular fluid, correction of acidosis, and increased urinary loss of potassium. If these changes occur too rapidly, precipitous hypokalemia may result in fatal cardiac arrhythmias, respiratory paralysis, paralytic ileus, and rhabdomyolysis. The rapid development of severe hypokalemia is potentially the most life-threatening electrolyte derangement during the treatment of DKA. As a general guideline, an initial serum potassium level of less than 3.3 mg per liter but more than 5.2 mg per liter before fluid resuscitation and insulin, coupled with urine output, calls for 20 to 30 mg per liter for at least 4 hours to keep potassium between 4 and 5 mg per liter. Because the most rapid changes occur during the first few hours of therapy, measure the plasma potassium level initially every 2 hours. If oliguria or renal insufficiency is present, withhold or decrease potassium replacement. Initial hypokalemia of less than 3.3 mg per liter is uncommon but necessitates a more aggressive replacement before insulin therapy. In this setting, give potassium IV at 20 to 30 mg per hour and hold insulin until potassium is greater than or equal to 3.5 mg per liter. There is no advantage to using potassium phosphate compared to potassium chloride because potassium phosphate may result in hypocalcemia and metastatic precipitation of calcium phosphate in tissues. Oral potassium replacement is safe and effective and is the preferred route of replacement as soon as the patient can tolerate oral fluids. In DKA, initial potassium replacement is usually by an intravenous line. Each institution may have specific guidelines for potassium replacement, but a general approach is a rate no faster than 10 milliequivalents per hour via peripheral IV or 20 milliequivalents per hour via central line access. Continuous echocardiogram monitoring is generally recommended while replacing potassium in the severely hypokalemic patient. During the first 24 hours, 100 to 200 mg or millimole of potassium chloride is usually required. In hyperkalemia, we have to obtain an electrocardiogram immediately and check for signs of hyperkalemia once DKA is suspected. Giving potassium to a patient in a hyperkalemic potentiating state, such as acidemia, insulin deficiency, volume contraction, and renal insufficiency, may dangerously increase the extracellular potassium level and precipitate fatal dysrhythmias. The initial measurement of serum electrolytes, electrocardiogram review for signs of hyperkalemia, and presence of urine output determine initial potassium therapy. An initial serum potassium level of greater than 5.2 milliequivalents per liter usually reflects a more profound acidemia and volume depletion or renal insufficiency. Fluid and insulin therapy alone will usually lower the serum potassium level quickly. Salbutamol nebulization can provide an additional quick potassium lowering effect. Low-dose regular insulin administration by an infusion pump is simple and safe, ensures a steady blood concentration of insulin, allows flexibility in adjusting the insulin dose, and promotes a gradual fall in serum glucose and ketone body levels. The half-life of IV insulin is 4 to 5 minutes, with an effective biologic half-life at the tissue level of approximately 20 to 30 minutes. After the initial fluid bolus or simultaneously in a second IV line, administer insulin at a rate of zero point 0.1 to 0.14 unit per kilogram per hour with no insulin bolus once hypokalemia is excluded. An alternative insulin regimen is zero point 0.1 unit per kilogram bolus IM if it is difficult to establish another IV line, followed by a drip rate at zero point 0.1 unit per kilogram per hour. An IV loading dose of insulin is not recommended in children and new onset young adult diabetics and is optional in adults. Plasma glucose concentration typically decreases by 50 to 75 milligrams per deciliter per hour, but if the blood glucose fails to drop by 10% 1 hour after initial therapy, or 3 millimoles per liter per hour, assuming adequate hydration, give a 0.14 unit per kilogram bolus and resume insulin drip rate. Another option is to increase the insulin infusion rate by 1 unit per hour. The incidence of non-response to low-dose continuous IV insulin administration is 1 to 2%, with infection being the primary reason for failure to respond. Resolution of hyperglycemia usually occurs earlier than resolution of the anion gap. So once the serum glucose is 200 milligrams per deciliter, add dextrose to the IV fluids and reduce the insulin drip rate to 0.02 to 0.05 unit per kilogram per hour. Maintain the serum glucose between 150 and 200 milligrams per deciliter until the resolution of DKA. Occasionally, a 10% dextrose solution may be needed to maintain glucose levels. Continue the insulin infusion until the resolution of DKA with glucose less than 200 milligrams per deciliter and two of the following: a serum bicarbonate level of more than 15 mg per liter, a venous pH of more than 7.3, and or a normal calculated anion gap. Monitor laboratory values every 1 to 2 hours to ensure that insulin is being administered in the desired amount. A transition from IV insulin infusion to subcutaneous insulin is necessary to avoid relapse to hyperglycemia or DKA when the insulin infusion is stopped. Relapse can occur quickly within an hour after IV insulin is stopped due to the short duration of action of IV insulin. The method of insulin transition varies and there is no set protocol. Once the patient eats, the glucose infusion can be stopped. In patients who can eat, the transition should include a short-acting and long-acting insulin given when DKA has resolved. One method consists of giving 10 units of subcutaneous regular insulin 30 to 60 minutes before the insulin infusion is stopped, and 80% of the usual long-acting insulin dose 1 to 2 hours before discontinuing the IV insulin infusion. Another method is to give 50% of the usual long-acting insulin dose 2 hours before the IV infusion is stopped for onset and duration of action of long-acting insulins. If the patient is a newly diagnosed diabetic, one can estimate a starting dose of long-acting insulin at zero point 0.1 to zero point 0.2 unit per kilogram. Additional glucose coverage can be provided with short-acting insulin as needed. Continue glucose checks every hour for 2 hours. Further intervals for glucose checks and the need for additional subcutaneous regular insulin dosing depend on the patient's response and institutional protocols. In uncomplicated mild to moderate DKA, the use of rapid-acting subcutaneous insulin may be another treatment option, although the standard treatment remains continuous IV insulin. The dose of subcutaneous rapid-acting insulin is an initial injection of zero point 0.2 unit per kilogram followed by zero point 0.1 unit per kilogram every hour, or an initial dose of zero point 0.3 unit per kilogram followed by zero point 0.2 unit per kilogram every 2 hours, or until blood glucose is less than 250 milligrams per deciliter. Then, the insulin dose is decreased by half and administered every 1 or 2 hours until resolution of DKA. This can avoid intensive care admissions and lower hospital costs, but still requires close nursing monitoring, difficult to accomplish in a regular hospital bed. Serum phosphate levels are often normal or increased in presentation of DKA and do not reflect the total body phosphate deficit secondary to enhanced urinary losses. Phosphate re-enters the intracellular space during insulin therapy, resulting in low phosphate concentrations. Hypophosphatemia is usually most severe 24 to 48 hours after the start of insulin therapy. Acute phosphate deficiency of less than 1 milligram per deciliter can result in hypoxia, skeletal muscle weakness, rhabdomyolysis, hemolysis, respiratory failure, and cardiac dysfunction. There is no established role for initiating IV potassium phosphate for DKA in the emergency setting. In general, do not give intravenous phosphate unless the serum phosphate concentration is less than 1.0 milligram per deciliter. Significant hypophosphatemia tends to develop many hours into therapy after the patient is already admitted. Undesirable side effects include hyperphosphatemia, hypocalcemia, hypomagnesemia, metastatic soft tissue calcifications, hypernatremia, and volume loss from osmotic diuresis. If absolutely necessary, such as a phosphate level less than 1.0 milligram per deciliter early in therapy, IV phosphate replacement should be administered as IV potassium phosphate 2.5 to 5 milligrams per kilogram. Monitor serum calcium level if giving supplemental phosphate. Osmotic diuresis may also cause hypomagnesemia and deplete magnesium stores from the bone. Hypomagnesemia may inhibit parathyroid hormone secretion, causing hypocalcemia and hyperphosphatemia. If the serum magnesium concentration is less than 2 milliequivalents per liter or symptoms are suggestive of hypomagnesemia, we give magnesium sulfate 2 grams intravenously over 1 hour. We obtain serum magnesium and calcium levels on presentation and 24 hours into therapy. Monitor levels every 2 hours if there's initial hypomagnesemia or hypocalcemia, or if symptoms suggestive of hypomagnesemia or hypocalcemia occur. Acidotic patients routinely recover from DKA without alkali therapy, as fluid and insulin therapy inhibit lipolysis and reduce or resolve ketoacidosis without added bicarbonate. We give bicarbonate if the initial pH is less than or equal to 6.9, but not if the pH is greater than or equal to 7. Severe metabolic acidosis is associated with numerous cardiovascular, such as impaired contractility, vasodilation, and hypotension, and neurologic, such as cerebral vasodilation and coma, complications. Theoretical advantage of bicarbonate include improved myocardial contractility, elevated ventricular fibrillation threshold, improved catecholamine tissue response, and decreased work of breathing. The disadvantages include worsening hypokalemia, paradoxical CNS acidosis, worsening intracellular acidosis, impaired oxyhemoglobin dissociation in a shift to left, hypertonicity and sodium overload, delayed recovery from ketosis, elevation of lactate levels, and possible precipitation of cerebral edema. During DKA treatment, hydrogen ion production ceases when ketogenesis stops. Excessive hydrogen ions are eliminated through the urine and respiratory tract. Ketone body metabolism results in the endogenous production of alkali. The decision to use bicarbonate in DKA patients should be based on the clinical condition and pH of the patient. Potential benefits of bicarbonate in the elderly with cardiovascular instability must be balanced against the potential disadvantages. There may be selected patients who benefit from cautious alkali therapy, including those with decreased cardiac contractility and peripheral vasodilation, and patients with life-threatening hyperkalemia and coma. Patients with severe acidosis may be at high risk for clinical deterioration, so adults with a pH of less than 6.9 can be given 100 mg of sodium bicarbonate in 400 ml of water with 20 mg of potassium chloride at 200 ml per hour for 2 hours until the venous pH is greater than 7.0. If the pH remains less than 7 despite the infusion, repeat the infusion until pH is greater than 7. Potassium is checked every 2 hours. Severe acidosis of less than 7.0 in pH and worsening pH despite aggressive therapy for DKA should prompt investigation for other causes of metabolic acidosis. Complications related to acute disease, that is, when there is a greater initial serum osmolality, BUN, and blood glucose concentrations, and low serum bicarbonate level, there is greater mortality, which includes infection and myocardial infarction being the main contributors to mortality. Additional factors that increase morbidity include old age, severe hypotension, coma, and underlying renal and cardiovascular disease. Severe volume depletion leaves the elderly at risk for deep venous thrombosis. Major complications related to therapy of DKA are as follows. For example, when there's a delay in diagnosis, blood glucose may be 250 to 300 milligrams per deciliter, and urine ketones may initially be negative. In unrecognized precipitating illness, electrocardiogram has to be checked for an infarction and examine the patient for a setting of infection. In patients who have inadequate fluids, majority of adult patients tolerate 15 to 20 milliliters per kilogram per hour of normal saline for the first hour. Additional fluids by clinical condition are serum sodium. If low potassium is unrecognized, this can lead to problems, and potassium has to be checked prior to insulin, and the potassium supplement before insulin should be given for patients who have a potassium serum level of less than 3.3. There's also an overemphasis in insulin sometimes, and this just means that we have to follow proper insulin guidelines. In hypoglycemia, the goal for glucose decrease of 50 to 75 milligrams per deciliter per hour is still espoused. We add dextrose if glucose is less than 250 milligrams per deciliter. For unrecognized electrolyte derangements, during the first 6 hours of treatment, we check glucose hourly and electrolytes every 2 hours. For overzealous use of bicarbonate and phosphate, sodium bicarbonate not indicated for pH more than 6.9, no routine indication for phosphate supplementation. For recurrent DKA, we avoid stopping the insulin drip until the anion gap resolves. We give subcutaneous insulin, feed the patient, stop insulin drip 1 to 2 hours before stopping the insulin drip. And for cerebral edema not recognized early, very young and new patients are at risk, so we perform frequent neurologic checks for mental status changes. Their premonitory symptoms are severe headache, incontinence, change in arousal or behavior, pupillary changes, blood pressure changes, seizures, bradycardia, or disturbed temperature regulation. Any change in neurologic function early in therapy is an indication for IV mannitol of 1 to 2 grams per kilogram. Mannitol should be given before respiratory failure or obtaining confirmatory CT scans because serious morbidity and mortality may be prevented. Hypertonic saline of 3%, 5 to 10 milliliters per kilogram over 30 minutes may be an alternative to mannitol. Intubation and fluid restriction are generally necessary. There's no data supporting glucocorticoid use in DKA-related cerebral edema. When it comes to later complications, metabolic acidosis refractory to routine therapy may be secondary to an unrecognized infection, and lactic acidosis, rarely insulin antibodies, or improper prep or administration of the insulin drip. Shock that is unresponsive to aggressive fluid therapy suggests gram-negative bacteremia or silent myocardial infarction. Hyperchloremic non-anion gap metabolic acidosis can develop during therapy due to rapid volume expansion in the face of reduced bicarbonate. In addition, bicarbonate equivalents are excreted in the urine as ketones and are replaced with chloride provided by normal saline. This emphasizes the importance of monitoring the anion gap during therapy. The non-ion gap metabolic acidosis resolves during recovery as bicarbonate is regenerated and excess chloride is excreted into the water. Late vascular thrombosis may occur in any muscle artery, although cerebral vessels appear to be most susceptible. Volume depletion, low cardiac support, or rather low cardiac output, increased blood viscosity, and underlying atherosclerosis may predispose the elderly to this complication. Thrombosis may occur several hours or days after institution of therapy and after resolution of ketoacidosis. Despite this increase in risk, no studies support prophylactic anticoagulant use, although some experts suggest the use of heparin may be beneficial in DKA if there's no associated bleeding disorder. Mortality in DKA results mainly from sepsis or pulmonary and cardiovascular complications in the elderly and fatal cerebral edema in children and young adults. So the best practice to prevent cerebral edema include slow reduction of osmolality during treatment, avoiding large volumes of hypotonic fluid, dropping blood glucose slowly during treatment, don't allow plasma sodium to fall during treatment, avoid unnecessary bicarbonate during treatment, and avoid hypoxia, hypokalemia, potassium, and magnesium. So when it comes to recurrent DKA patients, we look at insulin noncompliance, which is a major trigger for this recurrence, as well as cocaine being an independent risk factor, and patients using illicit drugs may benefit from drug rehabilitation. For patients with insulin pumps, if they're suspected to have DKA, they should have their pumps disconnected and turned off and should be treated just like any other patient. Reinstitution of pump therapy should start in the same time frame as switching over to subcutaneous insulin in the non-pump user. So, complications of diabetic ketoacidosis related to acute disease include loss of airway, sepsis, myocardial infarction, and hypovolemic shock. Related to therapy, hypokalemia, hypophosphatemia, acute respiratory distress syndrome, cerebral edema, and hypoglycemia. And later complications include recurrent anion gap metabolic acidosis, non-anion gap metabolic acidosis, vascular thrombosis, and mucormycosis. When it comes to DKA in pregnancy, it is one of the leading causes of fetal loss with a fetal mortality rate of approximately 30%. Several physiologic changes make diabetic pregnant women prone to DKA. Maternal fasting serum glucose levels are normally lower, which leads to relative insulin deficiency and an increase in baseline free fatty acid levels in the blood. DKA is triggered at lower sugar levels in pregnancy. Pregnant women normally have increased levels of counter-regulatory hormones. In addition, the chronic respiratory alkalosis seen in pregnancy leads to decreased bicarbonate levels due to a compensatory renal response, resulting in a decrease in buffering capacity. Pregnancy is associated with vomiting and urinary tract infections, which can precipitate DKA. Maternal hyperglycemia causes fetal hyperglycemia and osmotic diuresis. Maternal acidosis causes fetal acidosis, decreases uterine blood flow and fetal oxygenation, and shifts the oxygen hemoglobin dissociation curve to the right. Maternal hypokalemia can lead to fetal dysrhythmias and death. Correction of maternal hyperglycemia, acidosis, and electrolyte balance are the first priorities.